This meeting is being recorded.
A very good evening to all. I, on behalf of Institute of Pulmocare and Research, cordially invite you to Pulmocon 2021, the 13th session. Today, we will speak about lung cancer. To chair the session, I would like to invite Dr. Pawan Agarwal. Dr. Agarwal is a renowned pulmonologist and national faculty of the country. His primary areas of interests are infection with antibiotic resistance, non-invasive ventilation, and different aspects of treatment and management of asthma. He is a dynamic speaker in several national and international conferences like Bronchon, NAPCon, and others. He has several publications in national and international journals to his credit. He has extensive research experiences in NIV and infective lung diseases. Currently, he is associated with CMRI and Rabindranath Tagore International Institute of Cardiac Sciences, Kolkata. I sincerely welcome you, sir, and request you to kindly proceed over the meeting. Thank you.
So, good evening and big thanks to the entire team at the Institute of Pulmocare and Research under the guidance of Dr. Parthasarathi Bhattacharyya. It has really been, it gives me great pleasure to chair this session on lung cancer. And we have two eminent speakers taking us through this very interesting topic, which is continually evolving. And there are exciting developments occurring at a breakneck speed in its various dimensions. Screening of lung cancer, diagnostics, prognostication, therapy. Worldwide in 2020, it was estimated that there were 1.8 million deaths due to lung cancer. The incidence is falling in the developed world due to reduction in smoking. But unfortunately, it is rising in developing countries such as India because of increasing smoking. And this brings us to the central fact that tobacco control is perhaps the most pivotal aspect in managing this disease. So the first speaker this evening is Dr. Ashok Sengupta, who is a renowned pulmonologist of our city and has been a national faculty with more than 35 years experience in this field. He has a number of publications in various journals to his credit, and is a senior consultant in respiratory medicine at the Apollo Gleneagles Hospital in Kolkata. He is going to speak to us about the clinical aspects of lung cancer, when to suspect lung cancer, and how to diagnose it in our day-to-day practice. So over to Dr. Ashok Sengupta for the first talk.
Good evening, ladies and gentlemen. This is another session of Pulmocon, organized by Dr. Parthasarathi Bhattacharyya, renowned pulmonologist of Kolkata. And today my topic is suspicion and diagnosis of lung cancer in clinical practice. Lung cancer is a leading cause of death when the whole world is concerned. This is also a major healthcare problem in our own country. This is the commonest cancer and cause of death in men and women after breast, colorectal, and prostate gland cancers. The overall 5-year survival is a dismal 15%, and this number, believe it or not, hadn't changed much in the last 20 years. The disease is curable only if it is diagnosed early. Surgery still offers the best chance of cure, and at stage 1, 70% can expect to live for the next 5 years. There is another grim statistics. Worldwide lung cancer occurred in approximately 2.2 million patients in 2020, and with an estimated 1.8 million deaths. This is a huge tragedy. Lung cancer histology broadly can be divided into two groups, non-small cell and small cell lung cancer. Amongst the non-small cell group, the squamous constitutes the major portion. These are centrally located tumors, and there are other tumors as well. For example, adenocarcinoma, which are peripherally localized, And there is a special variety of it called bronchoalveolar carcinoma, which sometimes mimics pneumonia. There are varieties like large cell, also belonging to the non-small cell group. Surgery at an early stage of non-small cell lung cancer offers chance of survival, best chance of survival. And for the rest, that is advanced and metastatic disease, chemo and radiation remains the treatment. Small cell lung cancer usually presents with big mediastinal lymph nodes. It is notorious for early hematogenous dissemination, and treatment is usually a combination of chemo and radiation. Let us discuss a few risk factors for lung cancer. Globally, tobacco use is the greatest risk for lung cancer. It is reduced to a remarkable degree in ex-smokers. And for a second-hand smoke exposure, it is about, the relative risk is about 1.3. There are other environmental toxins, for example, people handling asbestos fibers or exposed to radon gas, or history of exposure to other elements like arsenic, beryllium, chromium, nickel. People who deal with soot, they also carry a higher risk of lung cancer. Certain comorbidities, for example, human immunodeficiency virus, idiopathic pulmonary fibrosis, COPD, tuberculosis, mostly as a scar cancer, can be of risk. Also, history of radiotherapy, history of chemo, family history of lung cancer, and old age itself can cause a higher risk for lung cancer. So how to suspect this dreaded cancer in time? The majority of the patients, unfortunately, have advanced disease at their presentation. This might reflect the aggressive biology of the disease and the frequent absence of symptoms until locally advanced. High-risk patients should be diagnosed while they still remain asymptomatic, what we call screening. And the symptoms may result from local effects, from pressure effects, or from regional distant spread effects, or from distant effects not related to the metastasis, what we call paraneoplastic syndrome. On presentation, this graph suggests the stage distribution at the time of diagnosis. You can see roughly just over a quarter presents at stage 1, and a huge proportion presents in stage 3 and stage 4, where the treatment becomes difficult. Stage 2 offers a meager 88% only. Symptoms of lung cancer in over 3,500 patients. Cough remains the top of the list, followed by wet loss, shortness of breath, chest pain, hemoptysis, bone pain, usually with periostitis or distant metastasis, hoarseness of voice when they present with recurrent laryngeal nerve palsy. These are certain paraneoplastic syndrome, and historically, Lambert-Eaton myasthenic syndrome has been given a special name and attracted all of us in our student days. And there are certain, importantly, SIADH causing hyponatremia, acromegaly, gynecomastia, encephalomyelitis, cancer-associated retinopathy, dermatomyositis, acanthosis, certain skin manifestations such as acanthosis palmaris, erythema gyratorum repens, and also nephrotic syndrome. Now let us see what the primary tumor can, how the primary tumor can be symptomatic, usually cough with hemoptysis, chest pain, wheezing, shortness of breath. If the tumor extends locally, the chest pain can be very severe. The superior vena cava obstruction may be there, hoarseness of voice with involvement of the laryngeal nerves, dysphagia with local pressure effects. Metastasis to the lymph node is the commonest metastasis. Bone pain, neurological deficits from the metastasis to the brain, skin and subcutaneous lesions as well. Certain paraneoplastic syndromes, for example, fever, anorexia, weight loss, SIADH, hypercalcemia, dementia, cerebral ataxia, myelopathy, peripheral neuropathy. Lung cancer screening is largely restricted to developing countries in spite of high prevalence of lung cancer, even in developed countries. Screening of lung cancer in developing countries pose a huge, big challenge. It is an effective method to detect cancer at an early stage. While there are regular screening recommendations for breast and cervical cancer, it is not so in the case of lung cancer. Various methods of screening have been tried, like chest X-ray, sputum cytology. However, the gold standard still remains as a low-dose CT scan of the chest. Newer modalities have also been considered in screening, for example, PET-CT, autofluorescence bronchoscopy, molecular biomarkers, hypermethylation of multiple genes, telomerase activity in sputum, etc. Exhaled breath analysis by means of special devices, sophisticated devices like electronic nose, breath print analysis, genomic and proteomic analysis of bronchoscopic samples. So why to screen the lung cancer? Because for lung cancer, we know there are identified risk factors which allows targeted screening. There is a significant prevalence with this type of cancer. A lengthy preclinical phase of some lung cancer has been observed. Evidence that therapy is more effective in early disease. Early detection allows more scope for surgical resection and cure. Awareness and better smoking cessation rates with screening. So these are the important positive factors in favor of lung cancer screening. Screening is followed usually these guidelines. The patient should be between 55 to 77 years old, currently smoking or an ex-smoker in the last 15 years, have at least a 30-pack year smoking history. What is low-dose CT? It is actually a non-contrast study obtained with a multi-detector CT scanner during a single maximum inspiratory breath hold, and high-resolution images are reconstructed. Radiation dose is rather low, 1.4 millisievert. Standard cumulative effect radiation dose, even after 10 years of screening, was not that much for women and men combined. Various randomized controlled trials have taken place with screening. To mention a few, National Lung Cancer Screening Trial in the USA. There are several European trials as well. For example, Nelson's trial, trial, German trial, LUSI, UK trial, UK LS, and Italian trials, to name a few. In the USA trial, more than 53,000 patients were inducted between the age of 55 to 74, smoking history of 30-pack years. And they are divided into two groups. And there has been a reduction in mortality relative ratios. Mortality is about 20% relative and absolute 0.3%. Limitations of screening in developing countries, the cost could be very high, and there are logistic issues as well. Also in developing countries like Southeast Asian countries, including India, high endemicity of tuberculosis is a challenge. Radiology and symptoms of both TB and cancer might overlap. And benign intrapulmonary nodules or lymph nodes often lead to false positive results. Overdiagnosis, radiation exposure, and the need for the confirmative invasive procedures. India currently lacks a proper framework for Asian scenario is even bleak for lung cancer. As per this Globocan study 2018, nearly 60% of all lung cancer cases were from Asia. Estimated incidence of over 1.2 million cases and approximately 1.07 million deaths. This has been attributed to high prevalence of cigarette or bidi smoking, hookah, indoor and outdoor air pollution. Mortality is high compared to the West. Average age of onset is about 40 to 50 years, and non-smoking lung cancer are also rising in India. Applying the USA criteria to Asian population, 91% lung cancer cases would have missed. That is a retrospective analysis. Western standards of risk calculators do not apply in TB endemic areas for reasons we described earlier. TB in Asia favors less reliance on even PET-CT scan. The epidemiology of lung cancer in India is a bit different from the Western society. For example, 52% in this study, 52% were non-smokers compared to 48% smokers. 14% were incorrectly diagnosed and treated with anti-TB treatment, which delayed the diagnosis of lung cancer. So the conclusion is Indian patients with lung cancer are non-smokers compared to the West. The global trend of rising adenocarcinoma is parallel in India. Non-tobacco related risk factors need further investigation. Evaluation of pulmonary nodules, which is again a occasionally could be difficult. It is easier when the clinician finds previous imaging, and if it is comparable to if it is compared to the previous one, it can be determined whether the nodule is stable or not. According to that, divided into two. If the nodule seems to be unstable, that is increasing in size, one has to go for high resolution CT scan of the chest. Again, depending upon the solid or subsolid nature of the tumor and depending upon the size, there are several steps to be taken, as we have shown here. Solid nodule more than 8 millimeter in diameter, it has to be referred to appropriate diagnostic center, and there is a pretest probability of malignancy, and that falls into 3 categories: low, moderate, and high. And depending upon that, serial CT surveillance, PET CT, surgical biopsy, leading to surgical resection occasionally, and in case of high probability, surgical biopsy followed by surgical resection remains the treatment of choice. Solid nodule less than 8 millimeter in diameter, again, probability low or probability moderate to high, depending upon the characterized nodule size. On the low side, less than 4 to 6, 6 to 8. Less than 4 poses a minimum risk. Patient discussion should be sufficient, and with increasing size, there should be involvement there should be investigation or screening at CT scan 12 monthly, and depending upon the possibility of malignancy, the CT scan frequency can be reduced. Annual CT surveillance after discussion with the patient based on clinical judgment and patient preference. That is the bottom line of this solid nodule investigation. American Society of Clinical Oncology and ACCP, their recommendations are more or less the same. Annual low-dose CT scan screening for high-risk individuals, ages 55 to 74 years with 30 pack years, or current smoker, or quit within past 15 years. This slide suggests some sites of human body where the material can be obtained for further study. For example, nasal scraping, exhaled breath, sputum, bronchoscopy sample, blood, urine, and several test material can be obtained from these things: RNA signature, volatile compounds, pre-invasive histology, chromosomal aberrations, DNA alterations, microRNA proteins, metabolites, and autoantibodies. Serum biomarkers in the screening, autoantibody assess, it could be complement fragment, circulating microRNA, circulating tumor DNA, DNA methylation, and blood protein profiling. Tumor epithelium can be investigated further with chromosomal aberrations to detect chromosomal aberrations, mRNA gene expression, and single nucleotide polymorphism, etc. Similarly, sputum, breath, and urine can be subjected to DNA methylation, microRNA, exhaled breath, tumor cells, urine markers, etc. remains other possibilities. Exhaled breath analysis is particularly of interest. There are cells and DNA fragments may even support detection of EGFR resistant clones. Volatile organic compounds like alkanes and benzene derivatives, and this can be assessed, collected, and analyzed by electronic nose, gas chromatography, and colorimetric sensors. There are certain sophisticated machines for this volatile compound collections. So once we reach the diagnosis, once we suspect, what is then the diagnosis? Diagnosis, what is the histology? How far has it spread? That is staging, and what can be done? That is treatment. Introduction of diagnosis of lung cancer, that should involve a detailed clinical history, clinical examination, radiological investigations, tissue diagnosis, immunohistochemistry, molecular diagnosis, and staging. The problem with early stage lung cancer is most of them are asymptomatic. Only 7 to 13% patients are asymptomatic at the time of initial diagnosis. Lung cancer is usually a diagnosis made during its later stages. Symptoms of advanced metastatic cancer, only 26% of patients have stage 1 disease and 8.3 stage 2. Majority are stage 3 or metastatic disease. Diagnostic evaluation and treatment of a patient with lung cancer requires a team: pulmonologist, medical oncologist, radiation oncologist, pathologist, radiologist, and thoracic surgeons. Modalities, it could be of diagnostic and staging. It could be non-invasive, it could be invasive. Non-invasive chest X-ray, chest, PET, CT, MRI. There should be search for metastasis, for example, nucleotide bone scan, CT, MRI, head, adrenal and hepatic imaging. Invasive diagnosis, diagnostic and staging techniques, for example, transthoracic needle aspiration, fiber optic bronchoscopy, endoscopic ultrasound, endobronchial ultrasound, metastenoscopy, and thoracoscopy. Chest X-ray first imaging study performed when primary metastatic lung cancer. Diagnostic pitfall, 5% cancer is retrocardiac, not visible in the usual PAB. There should be a high index of suspicion when there is a smoking history, persistent symptoms, history of exposure to radon, asbestos, etc. To compare with the previous and future chest X-ray is very important. CT scan still remains the key essential diagnostic test. It is used in staging since its introduction in 70s. It can localize site, size, and extent of the tumor, a locoregional spread. Usually, contrast enhanced CT chest with including the upper abdomen and adrenals are advised. Spiral or multiple dose CT with better algorithm creating reconstruction images of tumor, etc. To decide resectability. It can determine the size. Accuracy had been evaluated in 2 meta-analyses with sensitivity and specificity around 61 and 79%. Systematic review of medical literature performed by Duke University group reported a pooled sensitivity and specificity of 56%. In clinical stage 1A, only 6%. 60% of the nodes identified as malignant turns out to be benign. Similarly, approximately 20% of all nodes identified as benign by CT criteria are actually malignant. Another modality of staging is positron emission tomography. Sorry for the error. This can highlight areas of increased metabolic activity. Carcinoma cells are usually hypermetabolic, so PET can help with diagnosis and staging. Its drawback is cannot visualize brain. False positives can happen for infections and inflammatory lesions. False negatives also can be seen in smaller size of tumors or bronchoalveolar carcinoma, in situ adenocarcinoma, carcinoid tumors, or lymphoma. You still need tissue diagnosis after PET-CT. Further, non-invasive and invasive workup should be undertaken with paired goals of definitive establishment of histological diagnosis and, when indicated, molecular characterization of the tumor, determination of disease stage in the most cost-effective and least invasive manner. Tissue diagnosis, sputum cytology, least invasive way of achieving a histologic diagnosis. Yield is center dependent and requires a highly trained respiratory cytologist. Sensitivity could be as low as 42% and high as 97%. Yield increases with number of specimens, 68% for one specimen, 78 and 86% when 3 or more are involved. Diagnostic yield is higher with central tumors more than 2.4 centimeters, squamous cell histology, and hemoptysis. This lowest yield is peripheral lesions. Thoracentesis indicated when pleural effusion is present. Positive pleural cytology also establishes stage 4 disease. USG-guided thoracentesis improved the safety, revealed findings that raise the suspicion of malignant disease, including pleural thickening and nodularing. At least 50 ml should be sent for diagnostic yield. If it is initial negative, a second thoracentesis should be performed, and that increases the yield. Sensitivity to pleural fluid cytology can be as high as 72%. CT-guided needle biopsy, local anesthesia. This is good for larger, more peripheral tumors. Risk of pneumothorax is there. Accuracy is less than 60% for lesions less than 15 millimeter. It is reserved for patients who are not surgical candidates and who have got comorbidities or unresectable tumor, or if there is a suspicion of alternate diagnosis, for example, TB or lymphoma. Flexible bronchoscopy remains best for central and hilar tumors. Forceps biopsy yield is 74%, brushing 59%, washing 48%. Less helpful for small peripheral nodules. Autofluorescence bronchoscopy locates areas of epithelial thickness, can identify pre-invasive lesions and carcinoma in situ. Sensitivity is low. EVAS for sampling mid-external lymph nodes. For peripheral lung lesions by transbronchial biopsies. In 24 lung cancer resected specimens, comparison of tumor invasion on the basis of EBUS and histopathology findings showed same finding in 23 lesions and differ in only 1 lesion. So this is a good achievement by EBUS. These are various EBUS probes. Paratracheal, subcarinal, hilar, and interpulmonary nodes can be reached easily. Main blind spots for EBUS TBNA are the lymph nodes in the aortopulmonary window. as compared to CT and PET. EBUS TBN has a high sensitivity as well as specificity for mediastinal and high learning nodes. This is a rather less practiced procedure now, mediastinoscopy, where there will be surgical approach to the upper mediastinum and direct visualization and biopsy taking. Video-assisted thoracic surgery that can actually resect a tumor as well. Initially, the surgeon can have a present section biopsy followed by wider resection. Smaller tumors are difficult to localize via VATS. Preferred procedure for solitary resectable tumor and good operative candidate. So these are the modalities of diagnosis. Now we are coming to molecular diagnosis. Non-small cell lung cancer specimens are tested for various mutations. Testing for EGFR mutations and ALK translocations is standard of care for patients diagnosed with advanced lung adenocarcinoma. Various types of molecular diagnosis, for example, for adenocarcinoma, EGFR, KRAS, ALK1, and other driver mutations. Immunohistochemistry, judicious use of immunohistochemistry to preserve tissue for molecular diagnosis. Immunohistochemistry used to be used after consideration of all data from histopathology, patient history, clinical findings. Used in primary origin of cancer is uncertain. When there is neuroendocrine differentiation, CD56, chromogranin, synaptophysin could be of help. Malignant mesothelioma versus pulmonary adenocarcinoma is another important place where this immunohistochemistry comes into play. Liquid biopsy, circulating tumor DNA is that has been shed into the bloodstream. It can be present in 0.01 to more than 90% of the total cell-free DNA. The amount of cDNA is related to the tumor burden and varies between patients at different clinical presentation. It is collected, it is stable, it has a very short half-life ranging from 15 minutes to several hours. It is stable in plasma at -80. Blood can be sampled in EDT tubes. Preservative tubes can be used to stabilize in blood for up to 4 days at room temperature. Liquid biopsy then is subjected to different immunological methods, immunological and chromosomal studies to find out the abnormalities. So here we come to the end of the slides. Lung cancer remains a formidable enemy even in 2022. We need to improve the screening system, and we need to spread the use and importance of screening service to the developing world as well. Lung cancer is a relatively preventable disease. Nations should be united to stop menace of smoking and other exposure to toxins, industrial toxins and other toxins as well. That's all. Thank you very much.
So thank you, Dr. Ashok Sengupta, for a very extensive talk, focusing on various aspects of diagnosis, especially the screening aspects of lung cancer, which is extremely important. Because I don't really think we can achieve very significant goals in managing this disease unless we pick the disease early. And of course, that remains extremely formidable. So we'll discuss some of these issues in the Q&A session. Our next speaker is Dr. Mahapatro, who has extensive experience in the field of medical oncology for more than 25 years. His areas of special expertise include hemato-oncology, bone marrow transplant, and management of solid tumors. Dr. Mahapatro is an active member of the European Society of Medical Oncology, the Indian Society of Medical and Pediatric Oncology, and the European Society for Blood and Marrow Transplantation. Presently, he is the Director of Medical Oncology at the Apollo Multi-Speciality Hospital in Kolkata. He is going to continue with the management of lung cancer, focusing on early treatment. Over to you, Dr. Mahapatra, please.
Thank you, sir. Thank you very much. I'm just slide.
Yes,
Yeah. Thank you,
is
sir.
visible.
Thank you. Actually, my slides are actually supplied by Astra. Actually, talk is actually lung cancer, treat early, catch early. And so if you see about the lung cancer, actually, lung cancer in the world scenario, it's in the females, if you leave aside the skin cancers, it is second only to breast cancer in females and second only to prostate cancer in male. And if you see the death, it is the most killing cancer actually. And what is actually in Asian countries, especially in Japan, Korea, China, we are seeing lung cancer more in non-smokers actually, which are EGFR positive. Some countries EGFR positivity reach around 50% actually. So as per the India concerned, Globacon 2020 data, and in females actually overall breast cancer is the most common, and in females it's the fourth most common cancer, and in the male it is the second most common after head and neck cancers. So I will not go into detail actually. The 15% is actually small cell and 85% is actually non-small, and non-squamous is the predominant lung cancers. So if you see the staging actually, and we stage it as a TNM category, and T is actually as per the size and the invasion. Node actually, that is mediastinal node and hilar node, and opposite side mediastinal and supraclavicular nodes, and metastasis actually as because of prognosis, it is M1A and 1B, 1C. Actually 1A is pleural effusion and pericardial effusion and opposite side nodule, and 1B, 1C is extrathoracic nodule, and 1 and single. Because the prognosis are different, so they are in the TNM staging, they are differently put. So if you see about the surgery part, but if this is stage 1, stage 2, if somebody is fit, these are the patient, they can undergo surgery actually. But if they are not fit, then we treat as a curative intent with localized radiation. But these are the patient which can be clearly undergo surgery. And stage 3 actually is a broad category. If you see stage 3, some are operable actually, especially 3A, and these patients actually we give neoadjuvant chemotherapy, and in future we'll be treating this type of patient more with neoadjuvant chemotherapy with immunotherapy than surgery. Some 3B are actually operable, but it needs a multidisciplinary team approach with surgeons, pulmonologists, medical oncologists, and radiation oncologists. The other 3B, 3C are actually treated by chemoradiation. So this is the stage for lung cancer, and it all depends upon 1A, 1B, 1C, depending upon the number of metastasis, and because prognosis differs accordingly. But how this will differ in the current era of immunotherapy and the targeted drugs is not known. So if you see about the operable lung cancers actually and unoperable, globally actually 25% of the lung cancers are operable, 75% are not operable. But if you see in the Indian scenario, stage 1, stage 2 only comprise of the 3.5%, and total around 15% will be early stage, which may be operable, and maximum stage 3 patient they'll end up in chemoradiation, and operable patients are very less. Incidental pulmonary nodules. This is actually Southern California experience, actually 4.7 million patients, and there will be 32% incidental pulmonary nodules. So incidental pulmonary nodules are not uncommon actually. And we see also, if you see the PET scans, CT scans of different diseases, we see some pulmonary nodules. We don't know what are the pulmonary nodules actually. And actually, if you see a pulmonary nodule, so it's all depends upon the age of the patient. Actually, must be above 35 to be clinically significant. Whether the patient is smoking, if it's smoking, how many take care of cigarette smoking, what is the size of the nodules? Nodules less than 8 millimeter or little. If it is a solid or subsolid, if it is a solid and 8 millimeter less, the chance of malignancy are less. If it is more than 8 millimeter, then this chance of malignancy are high. If it is subsolid, whether it is increasing, any subsolid tumor which is increasing in size, and the size increase criteria is for 20 to 400 days actually. If it is increasing within this, then there is chance of malignancy are high. And if somebody have nodules in the upper lobe, the chance of malignancy is high. And we have a criteria actually. There's a risk calculator. So if you put the risk calculation, the chance of cancer will be calculated. So accordingly, you can go for biopsy. This is the Fleshner Society guidelines, actually 2017. This is updated in 2018. This is actually depends upon the size of the nodule and how you approach the size of nodule. If somebody has a bigger size of nodule, then either you have to do a PET CT or biopsy. And if you do a biopsy, the chance of pneumothorax is very high, but still you will end up in doing biopsy, or you will, if somebody invasive pulmonologist can do a EVAS or bronchoscopy, digital bronchoscopy, can do the FNAC of these nodules. This is low dose CT actually. We call it spiral CT. Patient low dose, patient just have a movement in the CT scan. This is a round movement, and the CT actually the scan reports are there. But it's not that CT scan is important. The radiologist who is reporting the CT scan properly is very important. And this is the National Lung Screening Trial, actually US trial. This is a 50%, 50,000 more patients, and it is actually you have to have 55 years to 74 years, and the CT scans are yearly 013, and after 6.5 years, actually there is a 20% reduction in mortality actually. And if you screen 1,000 persons, you will see 3 lung cancers. It is much more than what we do in breast cancer mammogram screening and screening for colorectal cancers. This is the Dutch and Belgian trial actually, and this is something different actually. 15,000 males and 2,500 females, and they have a baseline CT and 1, 3, and 5.5 years, and no screening actually. And they have a different criteria actually. National Lung Cancer Screening Trial has a criteria of 55 to 74 years and 35 years of smoking, and must not have left smoking within 15 years. This is actually, their criteria is actually 25 years and 50, more than 50 years actually, and less than 15 years of leaving cigarette smoking. And the cumulative benefit is around 24%. This is the pulmonary nodules in CT scan actually, and the benign nodules are mainly smooth round afferents, and lobulated, irregular, spiculated afferents are more of a malignant nodules, but still benign looking nodules may have 21% of the cases may have a malignancy. So whether our radiologists are telling it is the incidental pulmonary nodules or not, less likely they are telling there's incidental pulmonary nodules. Whether we are following up properly may not be, because if we follow up this, there may be some patient who will be diagnosed with lung cancer. These are actually some size criteria. How will you go at this per this size? But the Fleshner Society, this is also good if you follow this properly. And incidental pulmonary nodules, if somebody is have a incidental pulmonary nodules, if you see the CT scan, if somebody have in a remark they've written incidental pulmonary nodules, we usually see that. If it is written in the description part, usually maximum time we don't see. And actually mean time of diagnosis of incidental pulmonary nodule with lung cancer around 8 months. Actually, out of 3 patients, 2 patients are actually neglected. So this is the 2021 US Preventive Task Force recommendation actually. Whom to screen, this must be around 50 years. There must be 20 pack year of smoking and left smoking less than 15 years, and you smoke till age 80, or patient is not suitable for surgery for some other reasons. So what we don't have any smoking guidelines for non-smokers. The non-smokers lung cancer is increasing both in India and Asian countries actually. And in India, low dose CT scan are not actually available, or somebody who can properly read the low dose CT scan, whether it's the X-rays and X-rays reporting and with the artificial intelligence will work, we don't know. This is actually COVID, and COVID we saw a lot of CT scans. If somebody have a COVID, and the low dose CT scans were rampant actually, and some patient actually turned up to us with some nodules, but maximum times it's the reporting is cohorts, but sometimes patient come with nodules and they're being followed up actually with us. So whether it's COVID has started a new lung cancer screening, we don't know. Tuberculosis actually is common in India, and lung cancer, not all tuberculosis are lung cancer, or all patient with lung lesions are tuberculosis. So misdiagnosis is very common, especially we see a lot of patients which started with tuberculosis, especially in interiors by the general physicians, and especially they are lung cancer patients. So this is the screening guidelines actually. Screening guidelines either up to US criteria, up to either 55 to 77 years and 30 pack years, or the Dutch criteria 20 more than 50 years and 20 pack years of smoking. And this is all studies actually they tell ki early treatment leads to better survival. So this is now the management what we practice actually. Lung cancer, if we tell it is a stage 1 to stage 4, actually stage 1, stage 2 different, stage 3 is different, stage 4 is different. Stage 1, stage 2, if somebody is operable, we tell them to operate, and we need pulmonologist support and cardiologist pulmonary support. If somebody get operated, then we give adjuvant chemotherapy. And this actually field 1 to 3 years, this field actually now has been a little bit changed, and in the future actually if somebody has a 1 to 3 year operated, they will be treated with either targeted drugs or immunotherapy. And 3B, 3C inoperable, we treat with chemoradiation. If stage 1, stage 2, if it is not surgery, we do usually chem radiation as a curative intent. If size is very small, sometimes stereotactic radiation or radiofrequency ablations. If stage 3A, then we usually give chemotherapy and chemo radiations. And if you do a lung cancer surgery, long-term survival is around 40%, and 60% the patient, the disease comes back. The chemotherapy benefit in 5 years is only 5%. Surgery is actually, we prefer lobectomy, and sometimes vaginoresection segmentomy. Pneumonectomy, very fit patient and young fit patient. Radiation, either it's a curative in stage 1, stage 2, and sometimes very small tumor we give as a stereotactic radiation. In India, actually, maximum patient cannot afford costly targeted therapy or immunotherapy, and they'll end up in chemotherapy after relapse of surgery or chemoradiation or straight stage 4 cancer. And now, actually, what is new? This is actually, this trial changed our practice, how you treat after surgery. Actually, maybe in future we'll see more patient with surgically operable having mutations treated by targeted drugs. This is called ADORA trial. This is EGFR positive patient. In India, we have 20 to 30% EGFR positive patient, and surgery patient are 1B or 3A actually. If somebody is EGFR positive, they have undergone surgery, you give chemotherapy or you don't give chemotherapy. Then it's the targeted drugs is EGFR inhibitor, class 3 drugs is osimertinib, and is versus placebo. You can see the benefit of osimertinib if you give. Its benefit is much in stage 2, 3A, and stage 1B patient, they do well with surgery, and the benefit is little less. But whether you give chemotherapy or don't give chemotherapy, you give osimertinib, and the benefit, there is 83% risk, 80% around risk reduction of disease-free survival. This is the stage wise. 1B is highly curable, so benefit of, still the benefit of osimertinib is there. This is the, because this patient just survive long, overall survival is not mature, but what the early graphs indicates, there will be a overall survival advantage. Previously, there was a lot of trials of actually first generation EGFR inhibitors like gefitinib, erlotinib in operated lung cancers, and actually the trials were negative. The problem is EGFR inhibitor, this EGFR positive patients, lung cancer, their relapse is more of in a CNS actually, and first generation erlotinib, gefitinib doesn't penetrate CNS well. So this is osimertinib is highly CNS penetrating. So the CNS disease-free survival is equivalent to peripheral disease-free survival. So this trial, because of high CNS penetration and selective EGFR inhibitor, the trial was positive. So if somebody is a EGFR inhibitor, maybe 20 to 30% of the patient who are operable, and if their EGFR inhibitor positive, they can afford osimertinib, and osimertinib is the best treatment, whether you give chemotherapy or don't give chemotherapy. So if you see the lung cancer, when I was doing MD actually, hardly there was any drug for lung cancer, and things has changed very drastically, and recently very much. We started with actually histological driven chemotherapy. We started little bit with bevacizumab, but now with all the targeted drugs and immunotherapy, the treatments of lung cancer is very much different now. So histological driven chemotherapy, like if it is adenocarcinoma, Pemetrix based, it's a squamous cell, then gemcitabine based. But if you see the targeted therapy now in adenocarcinoma, more than 80% will be having oncological driven mutations, and in squamous cell, more than 60% will be having oncological driven mutations. And some are targeted now, some will be maybe targeted will in future. And if there is no targeted therapy, then those other patient will be treated with immunotherapy. So what we want actually, we want a good biopsy. Bronchoscopically, biopsy is there. We are very comfortable because tissues are more, or otherwise we tell the radiologist to have a good core of the tissues, so that we need the biopsy not only for ISC but of the molecular profiling. So because of lot of huge targets actually nowadays, and if you do RT-PCR of the all the targets, and you will end up in utilizing your tissue. So next generation sequencing we advise, and there is a broader next generation sequencing. So usually the turnout time is actually to around 2 weeks, and if somebody is not symptomatic, we wait for 2 weeks to get the NGS reports. If you see the targetable in lung cancer, actually, this is EGFR, and we have a multiple drugs actually, and drugs are coming also. All we have 4 drugs now, and MET we have capmatinib now in India, and HER2 inhibitors actually will be available. Trastuzumab emtansine will be available shortly. ROS1 we have medicines available, and BRAF we have a medicine tramatinib, dabrafenib, tramatinib we have available. RET actually we don't have medicines available, but if somebody have a RET mutation, then ROS can give RET inhibitors in a compensated ground. NTRK, this is less than 1% in all solid tumors, and we don't have the medicines. And KRAS actually, after EGFR, KRAS is actually one of the biggest mutation, and G12C we have a sotorasib, but it's not in available in India. But in the future, maybe will be lot of patient will be treated by the targeted drugs in the beginning. So if not targeted drugs, then immunotherapy. Immunotherapy is actually what the tumors do. They have a PD-1 actually in the T cells and PD-L1 in the tumor cell. Because of interaction between PD-1 and PD-L1, they suppress the immunity. The immunotherapy drugs are actually either is a PD-1 inhibitor or PD-L1 inhibitor. What they do, the suppression immunity, they break that circle, and the tumor immunity of the body is restored. So usually the body's immunity, they work with the cancer cells, and we have a lot of autoimmune syndromes, but the autoimmune syndrome chance is very less. So we do PDL expression, it is a immunohistochemistry testing, but if you are starting with the immunotherapy and chemotherapy, we don't need PDL1. But some, like if we do surgery and after the surgery we do the PDL1, there are different types of PDL1. If somebody has a PDL1 positive more than 1%, and after chemotherapy, they can be treated with immunotherapy like atezolizumab. So this is the standard now, FDA approved. So stage 3 lung cancer. Stage 3, if it is not operable, they are treated by chemoradiation. But the long-term outcome of the chemoradiation is very less. But 5-year survival around 15 to 25%. And stage 3 lung cancer is very tricky actually. They need a multidisciplinary approach, and pulmonologist, medical oncologist, surgeon, nutritionologist, radiation oncologist, everybody, radiologist, pathologist. So need to be worked up properly. You need EVAS to stage properly, and the patient fitness, MRI brain, and the treatment will be either concurrent chemoradiation if somebody fit, or give chemotherapy, then give radiation sequencer. So to improve outcome, lot of things were tried in stage 3 lung cancer. Whether you give more chemotherapy, give targeted drugs like cetuximab, or increase the radiation or fraction of radiation, but nothing worked. Till this trial actually, which changed the to change how we treat stage 3 lung cancer. This is actually Pacific trial. This is immunotherapy durvalumab after chemoradiation. 1 to 42 days after chemoradiation, you give durvalumab 10 milligram kg for body weight for one year, actually every 15 days for 1 year versus placebo. You can see the overall survival is around 43%, 5-year overall survival, actually, which was not before. And if you see the PFS, actually 33% PFS, actually there is 33% are progression free, and around 43% are surviving after chemoradiation, which is equivalent to actually if you do a surgery in the stage 3 lung cancers. This is the subgroup analysis. Every subgroup is benefiting, and the side effect is more of a pneumonitis, actually. And if you see about the number of pneumonitis is more in the immunotherapy group, but if it is a grade 3, grade 4 pneumonitis, which is a concern, is equivalent in both chemoradiation group and immunotherapy group. So this is actually small cell lung cancer. This is a very difficult disease to treat, and there were a lot of still the cisplatin or carboplatin with etoposide is the standard chemotherapy. There were a lot of combination and permutation which never increased the survival. This is the actually Caspian trial. This is there is 2 immunological drugs in small cell lung cancer. One is atezolizumab and one is durvalumab. This is the Caspian trial of durvalumab, actually. There was 3 arms, actually: chemotherapy with immunotherapy durvalumab, chemotherapy with durvalumab with CTLA4 inhibitor, and one is only chemotherapy. Actually, you give 4 cycles of cisplatin etoposide or carboplatin etoposide, and either with immunotherapy and immunotherapy with CTLA4 inhibitors, or in the chemotherapy arm you give 6 cycle, which is standard what we practice. This is OS, actually. If you can see the OS, actually, and both 1 year, 1.5 year, 2 year, and in 2 year, actually 22% of the small cell carcinoma patients are surviving. If somebody is doing well, they will be doing well. The response are prolonged. And if you see the PFS, actually, and 11% at 2 year patient are progression free. Actually, this is the first trial which has seen small cell carcinoma. It is hard to see some patients surviving 2 years, and this is the first trial to show as 2 years data. So if the response is also better in the durvalumab arm, and immunotherapy with platinum and etoposide, if somebody can afford, will be the standard of care in small cell carcinoma. And actually, what we are doing exactly same. We are discussing with the family about the immunotherapy part. Thank you.
So, thank you, Dr. Mohapatra, for a very, very extensive review of the field of lung cancer management. Although there are a lot of exciting developments which are occurring in this field, and I'm sure the care of most of these patients will improve, I still think for a country like India, there are huge challenges, right, starting from diagnosis. So this is open for now questions and answers. So if anybody would like to pose any questions to the 2 speakers this evening, please. Do we have any questions for the speakers? Are we live?
Yeah, there are 2 questions in the question answer box.
Okay.
Can you find that question?
Yes. Yeah. So the first question is from Dr. Arun Chakravarti. He wants to know what are the new modalities of treatment in Pancreas tumor. So this would be to Dr. Mahapatra, I think.
Pancreas tumors are what we do actually mainly chemoradiation and surgery. This is the pancreas usually squamous, and we do chemoradiation and surgery mainly. If somebody is operable, if somebody is not operable, then usually because they penetrate the brachial plexus, we offer them radiation, and after that it's like a typical squamous cell carcinoma treatments.
The next question is by the same gentleman, and this is addressed to Dr. Ashok Sengupta. So he asked, what are the percentage of non-smoker lung cancer in Asian countries? And are women more affected? So I think there was some data which he showed from a study done at Tata Memorial, where they showed that half the patients are non-smokers in our country. Would the panel agree with this? Or is this, do you think this is not really a representative data, just a single center study? So what would be the percentage of patients in our country who are non-smokers with lung cancer and women with lung cancer? Is anybody could answer this, any of the panelists?
TMH actually, what TMS data is actually maybe single center, sir, but the patient of TMH are actually from all over the India. I mean, it is actually data of TMH will be reflecting of the all of over the India. What we see actually more patient of non-smokers having lung cancers, and that is what is happening actually.
So what do you think would be the reason for this? Why are we having so many patients who have lung cancer who are non-smokers? So there's a huge difference between our data and the Western data. So what do you feel are the reasons behind this? What could be responsible for this?
Exactly, you cannot tell. It is a multifactorial actually. What we are having actually, it is reflective of Asian countries actually. More of a lung cancer occurring more in non-smokers actually, and it is actually multifactorial. Maybe start with the pollution and mainly passive smoking, pollution. Radon, we don't know what is. Yes, asbestos is not common nowadays. But it is more of a diesel fume, so it's a multifactorial.
So it could be genes and it could be the environment interaction. Yes, and that is one of the reasons we also have a higher incidence of the driver mutations in Asian population than in the Western population, isn't it?
Yes.
So the driver mutations are much higher. Can I ask one question? This is regarding screening. Very honestly, screening for a country like India is going to be highly complex because the logistics it involves, the cost it involves, and the whole organizational aspect of medicine it involves. I really don't think in the near future we can really have a national screening program. So even if you look at the reading of chest radiology between two radiologists, so if you have two radiologists reading the same film, your pickup rate increases by 10 to 15% if they are nodules. So obviously the future lies, I think, in some form of computer-aided diagnosis and artificial intelligence in terms of how the CTs are read. So the real crux of how we reduce this burden of lung cancer really boils down to reduction in smoking. And of course, identifying factors which are responsible for non-smoking lung cancer in our country. So I personally think screening really is not viable in our countries at this stage on a very large scale. What is your sort of feeling towards it?
Definitely, sir. It's not only screening actually, properly screening, identifying the proper person, the financial aspect of the screening, and whether the low dose spirality availability in the centers, and the main person who is reporting it, whether they are reporting properly or not. And again, after that, doing the proper biopsies like the small nodules actually with the chance of pneumothorax being high. That is very all combined it's very difficult with them in a country like India.
Yeah. Today is Dr. Ashok Sengupta with us. Has he joined us?
No, I don't see him.
You can't.
But
Yeah.
I appreciate your comment that somewhat artificial intelligence can be of very high use for a country like us, especially for screening.
Yeah. So there's another question on the role of autofluorescence. So Dr. Sengupta is not here really to answer this, but so far it has proved fairly disappointing in real practice. So theoretically, it offers advantages and it can detect squamous cell cancers, not really adenocarcinomas. But most of the trials have been pretty small. So as a clinically useful tool, I think it is still not well established. The other is the question is on liquid biopsy. So what is Dr. Mahapatra's views on liquid biopsy?
What we are doing in liquid biopsy is actually, if somebody have a less tissue actually, and they don't, the tissue is not sufficient and the patient doesn't want a re-biopsy, or re-biopsy will be difficult, those patients we are doing liquid biopsies for mutation testing. Or sometimes if patient progresses with the targeted drugs, we are advising liquid biopsy. But if liquid biopsy is not picking up the desired result, we still advise for the re-biopsy and do the mutation, because the concordance rate of liquid biopsy and solid biopsy around 75 to 80%.
There's another question on the average cost of treatment in stage 3. Now, this is, I think, a very difficult question to answer because it depends on what stage 3 stage and whether you have actionable mutations, because then the cost of treatment depends a lot on that. But can you tell me what is the cost of durvalumab for 1 year?
Durvalumab, sir, I think it will be around 15 to 20 lakhs around. They have a support. They have a support program actually. To buy one, they will give one cycle free. So around 15 to 20 lakhs around.
Yeah. So obviously, it is, I think, out of reach for the vast majority of population, because that's just the cost of one drug.
Definitely.
And you the drugs, follow up, investigate. What is the cost and turnaround time of your next generation genome sequencing now? So are there labs which are doing fairly sort of in a routine way now?
Maximum labs have started doing the next generation sequencing actually. But how much actually is the validity of those tests to it's very difficult to tell, but there are some good labs who do actually next generation sequencing, and the reports are available within 2 weeks. And if somebody has the money and we send them
what is the cost of it?
Next generation sequencing are very cheap, sir. Nowadays, actually, companies are giving us coupons, and the 14 genes, you can do it in 8,500 rupees.
Oh, just 14 genes, because I had to get somebody is done from within my family. The 500 genome sequencing, that is close to 2 lakh rupees, I think,
This is I told sir, actually, if somebody has the money, this is the best foundation one. They take the foundation was the best, but they cost around 2 to 2.4 lakhs around, and they have the best sequencing, but the turnout time is around 3 weeks actually.
Yes.
And if it is actually not foundation one, then Indian actually 2 weeks around.
Okay. So the other question I had was, what is your experience for sputum cytology for picking up lung cancer? Because very honestly, in the last 5 years, I've not seen a single patient in our country who has been picked up on sputum cytology for lung cancer. So where is the problem? Is it the way the cytology is handled, or is it the expertise with the cytopathologist? Because I rarely see a patient who has ever been picked up on sputum cytology, a patient of lung cancer.
Actually, sir, we are not doing sputum cytology often because I think we get patient mainly diagnosed by pulmonologist
Yes.
can come to us, and if somebody with a CT scan come to us and they have a clear-cut lesion, either we go for biopsy or we go for bronchoscopy if it is a central lesion. Sputum, because of squamous cell carcinoma being decreased actually in
Yeah.
adenocarcinoma, and less patient will be picked up in sputum cytology.
Parthoda, what is your experience of sputum cytology?
I have seen 1 or 2 reports earlier, but of late I have not seen any report of sputum cytology.
Yeah,
I think the zeal and expertise matter a lot in the pickup rate in sputum cytology, which people are
yes.
losing.
So I don't think there are any more questions. Do you have any questions, Parthoda?
Okay.
So if there are no, let me see, there is. So there's one question, but I think it's an incomplete question. Is there any monoclonal antibody in pipeline for treatment of? Dr. Chakravarti, could you type it further? Treatment of what?
It's incomplete. You can't.
Treatment of a particular cancer or small cell, non-small cell? So there are no further questions. I think we can close this session today. It's been very informative. It is a difficult topic actually, and it is fairly exhaustive. And there have been a lot of developments, and I think there will be continuing to be further developments. The challenge is how to apply it very judiciously in our country, because most of these new treatments are going to be very, very expensive. So it all boils down to the fact between the cost benefit ratio, So, quality adjusted life here, for example, even if you look at the lung cancer screening program, the cost is more than $150,000 for each quality adjusted life year for the lung cancer screening program. So basically that is huge, so that is the amount of money you have to spend to gain 1 year of life, as a population as a whole. So I think the best bet for lung cancer still remains prevention and, focusing on tobacco cessation and reducing smoking, to me is, I think, still the most important goal in this field.
And also pollution, perhaps.
Yes. Oh, that is a huge reason. I think that is one of the main reasons why we have such high non-smoking lung cancer. So, it's both water pollution, air pollution. Our groundwater is polluted by all kinds of, heavy metals and chemicals. Similarly, the air pollution. Otherwise, why should we have such high rates of non-smoking lung cancer,
Yeah, nowadays, because of the irrigation system in our country, all the food grains are being contaminated with a lot of heavy metals, especially arsenic. And it is not the water which has turned the source of arsenic toxicity, it is the food grains. And so we are naturally exposed to such heavy metals that are carcinogenic. And possibly these are the reasons. If you look at the whole scenario, the cancer incidence and prevalence of cancer is far exceeding the natural curve of any other disease. They are increasing like leaps and bounds. And see the industry also, in the health industry, the oncology services getting very huge pressure, highly demanding. So what has happened in last 2-3 decades?
All corporate hospitals are focusing on oncology the most.
So it's a very, very important issue now to get rid of it. And prevention should be the most important area of focus. but we do not know. A lot of research is essential. So Pawan, thank you for such wonderful, wonderfully
Noted.
managing. Yeah, it's very good, and we enjoyed your comments. And I'm really grateful to our speakers, especially Dr. Mohapatro, who has talked so extensively and beautifully explained everything. Also to Ashok Da, although he's not out here.
Thank you very much.
Thank you, sir. Thank you. Thank you.